Hello students, today we got lecture number 15, Endocrine Glands, their role in the growth and development of children. Research methods of the endocrine glands, semiotics and syndromes of endocrine system damage. The endocrine system unites the endocrine glands, the cells of which produce and release into the internal environment of the body special biologically active substances, hormones that bind to the receptors of target cells and regulate their functional activity. The organs of the endocrine system are divided into the following groups: hypothalamic pituitary system, neurosecretory neurons of the hypothalamus and adenohypophysis, brain appendages, nerve hypophysis, and pineal gland. Bronchogenic group originating from the epithelium of the pharyngeal pocket, thyroid, parathyroid, and thymus glands. Adrenal system, cortex and medulla of adrenals, main body, islets of Langerhans of the pancreas, and endocrine cells of the genital glands, testicles, and ovaries. The function of the endocrine system are to regulate the activity of various body systems and to monitor the process of growth, development, reproduction, adaptation, and behavior. The endocrine system is built on the principles of hierarchy, a subordinance of a peripheral unit to central one, and change formulation stimulating hormone with a lack of the hormones of periphery, horizontal network of interaction of peripheral glands with each other, synergism and antagonism of certain hormones, reciprocal autoregulation. Hypothalamus. Hypothalamus forms lower parts of the interbrain and is involved in the formation of the floor of the fourth ventricle. Clusters of nerve cells form 32 pairs of nuclei of hypothalamus. Most of the humoral factors produced at the level of the hypothalamus are called releasing hormones or releasing factors, stimulating factors, and inhibiting factors. Pituitary. The pituitary gland is located in the cell turcica, a depression in the base of the skull. From the cranial cavity, the pituitary gland is limited by a fold of the dura mater, diaphragm of the cell turcica, by a thin stalk that penetrates through the diaphragm. The pituitary gland is connected to the hypothalamus. The pituitary gland develops from two separate primordia. One of them, the outgrowth of the ectodermal epithelium, Rathke's pocket, is laid in the human embryo at the fourth week of outerine life, and the anterior and middle lobes that make up the adenohypophysis are subsequently formed from it. Another element is the outgrowth of the intestinal brain, consisting of nerve cells from which the posterior lobe or neurohypophysis is formed. The pituitary gland begins to function very early, from the 9-10th week of intrauterine life. It's already possible to determine the trace of ACTH. In newborn, the weight of the pituitary gland is 10-50 mg, and by the period of puberty it increases by about 2 times, reaching 20-35 mg. In an adult, the weight of the pituitary gland doesn't exceed 0.5-0.8 gram. Its size increases with age, which is confirmed by an increase in the cell turcica on radiographs. The average size of the cell turcica in newborn is 2.5 to 3 mm, by 1 year old 4 to 5 mm, and in adult 10 to 15 mm. In the pituitary gland, 3 lobes are distinguished: anterior or adenohypophysis, 75% of the pituitary gland; intermediate or glandular, 1-2%; and posterior or narrow hypophysis, 18-23%. The anterior pituitary consists mainly of glandular chromophobe cells. More eosinophilic and oxyphilic, then basophilic. The intermediate lobe is represented with basophilic cells. The posterior lobe and stalk of the pituitary gland are formed by elements of nerve fibers and pituitary. In the intermediate, the melanephron hormone is formed. In the posterior lobe, hormones are not synthesized. ADH, oxytocin, and neurophysins enter the hypothalamus along the axons of hypothalamic pituitary tract. During clinical examination, it is possible to identify certain signs of dysfunction of the pituitary gland, for which the length and weight of the body, the dynamics of their increase, the state of tissue trophism, the development and distribution of subcutaneous adipose tissue. The timelines of the appearance of secondary shock characteristics and also the neurological status are assessed. In addition, diuresis should be measured urine specific gravity, potassium and sodium ion concentrations, and osmolarity of blood and urine determined. Indirectly, the state of the pituitary gland can be judged by the size, shape, and structure of the cell torsicle on radiographs. More accurate data are obtained with computed tomography and MRI. To determine the functional state of the pituitary gland and hypothalamus, immunological methods are used to study the content of hormones in the child's blood. The maximum release of growth hormone occurs during nighttime sleep. To assess the concentration of STH, its initial secretion is determined, and then the study is repeated after stimulation tests, insulin, clonidine, etc. Hypopituitarism, a deficiency of one or more pituitary hormones, can occur with disease of the pituitary gland or hypothalamus. The causes of hypopituitarism in children may be anomalies in the development of the central nervous system, tumors of the hypothalamus or pituitary gland, traumatic brain injury, syndrome of empty Turkish cell, hydrocephalus, infections, autoimmune lymphocytic hypophysitis, vascular thrombosis, hemorrhage, granulomatosis, iatrogenic factors, complication of glucocorticoid radiation therapy. Cause of the female form of multiply hormone deficiency of the hypophysis can be gene mutations. Lack of hormones affecting the peripheral endocrine glands causes their dysfunction. TSH deficiency is the cause of secondary hypothyroidism. Gonadotropic hormone deficiency is cause of secondary hypothyroidism. ECTH deficiency, secondary adrenal insufficiency, and hypopigmentation. GIH deficiency in infants can cause hypoglycemia, growth retardation in prepubertal age and in adults. It can cause wrinkles around the eyes and mouth, excess of belly fat, and a decrease in muscle weight. Lack of protein manifests in lactation disorders. Partial hypopituitarism occurs as a result of a deficiency of any one of the tropic hormones. The most common disease associated with partial hypopituitarism is pituitary dwarfism, caused by a deficiency of STH and gonadotropins. An isolated deficiency of gonadotropic hormones leads to a delay in sexual development. It doesn't begin or end, and is manifested by symptoms of secondary hypothyroidism. In most cases, this condition is caused by congenital defect of gonadal membrane, rarely by congenital or acute deficiency of gonadotropic pituitary cells. The most common congenital isolated deficiency of gonadotropic hormones occurs in Kallmann syndromes, anosmia, lack of color vision, facial defects in the midline, and Lawrence-Moon-Barnes-Bidle, mental retardation, polydactyly, obesity, retinitis pigmentosa, deafness, short-stature diabetes insipidus. This latent ACTH deficiency rarely develops and leads to hypocorticism, and more often a relatively mild form of adrenal insufficiency is observed, the symptoms of which usually appears only under stress. Hyperpigmentation and an increased needs for table salt are not typical. TSH deficiency clinically manifests in hypothyroidism. With pituitary hypothyroidism, the concentration of TSH after the administration of pyrrolidine remains low, and with hypothalamic hypothyroidism, it increases. Hypothyroidism is often partial. The reason for increases in production of pituitary hormones may be a tumor process. Adenoma, diencephalon tumor, suprasellar tumor, craniopharyngioma, encephalitis, or a degeneration process in the brain. Excessive growth hormone production in children before the closure of the growth zones of the epiphyseal cartilages is the cause of the appearance of pituitary giantism or telomeres. In adults, after the closure of the growth zone of the epiphyseal cartilage, acromegaly, which is characterized by thickening and deformation of the bones, an increase in the weight of soft tissues, and internal organs, metabolic disorders. Increased secretion of melantropism can lead to irritability. With an excess of TSH, the concentration of thyroid hormones increases clinical signs of the thyrotoxicosis and goiter appear. Excessive secretion of ACTH leads to the development of Sanger-Cushing's disease. With excessive protein production in girls, sexual development is delayed or impaired. Galacta, oligo, or amenorrhea develops in women, and gynecomastia occurs in men. Diabetes is manifested by an impaired concentration of urine, polyuria, polydipsia, and frequent mutation. Central diabetes insipidus is caused by a deficiency of ADH, primary as a result of mutation in the ADH gene and enzymes of its synthesis, or secondary with tumors, histiocytosis, X, granulomatosis, infection, anomalies of blood vessels, traumatic brain injury. Nephrogenic diabetes insipidus develops with renal insensitivity to ADH. The syndrome of hypersecretion of ADH is characterized by hyponatremia, hypoosmolarity of plasma, and excretion of concentrated urine. In children, hypersecretion of ADH occasionally occurs with disease of the lungs, pneumonia, tuberculosis, or the brain, infections, hemorrhage, pneumonic brain injury, intracranial hypertension, tumors. In addition, in newborns, the cause of ADH hypersecretion can be positive pressure ventilation. In older children, the use of vincristine, cyclophosphamide, chloropropamide, some analgesics, and barbiturates, as well as heart disease, severe hypothyroidism, primary adrenal insufficiency. To judge upon functional state of the pituitary gland, in addition to clinical data, various laboratory parameters are also used. At present, these are primarily direct radioimmunological methods for studying the levels of hormones in the child's blood. Growth hormone, HGH, is found in the highest concentration in newborn. In a diagnostic study of the hormone, its basal level about 10 nanogram in 1 milliliter, and the level during sleep are determined when there is a natural increase in the release of growth hormone. In addition, prolongation of hormones release is used, creating a moderate hypoglycemia by administering insulin or other stimulants. During sleep and stimulation, the level of growth hormone increased by 2-5 times. The level of adrenocorticotropic hormone in the blood of a newborn is 12 40 nanomole per liter. Then it drops sharply, and at school age is 6-12. The level of thyroid-stimulating hormone in newborn is exceptionally high, 1199. In other age periods, its concentration is 50-20 times lower. Luteinizing hormone in boys at a young age has a concentration in the blood of about 3-9, and by the age of 14-15, it increased to 10-20. In girls over the same age interval, the concentration of luteinizing hormone increases from 4-15 to 10-40. The increase in the concentration of luteinizing hormone after stimulation with gonadotropin-releasing factors is especially indicative. The response to the introduction of the releasing factors increases with puberty and rises from to 3-fold to 6-10-fold. The level of follicle-stimulating hormone in boys from junior to senior school age increases from 3-4 to 11-13. In girls of the same age from 2-8 to 3-25. In response to introduction of the releasing factors, the secretion of the hormone approximately doubles or grades regardless of age. Epiphysis. Epiphysis of pineal gland belongs to the hypothalamus or the diencephalon and is connected by a hypothalamus to the thalamus. The function of the pineal gland is not well understood. It is believed that it's involved in the implementation of biological rhythms in human body, has an impact of puberty and gonadal function, inhibits the activity of the thyroid gland. The weight of the pineal gland at birth is about 7 mg and increases to 100 mg during the first year of life. By the age of 10, it almost doubles and doesn't change subsequently. The size of pineal gland in newborns is 2.6, 2.3 and 1.7 mm. At the age of 10 years, it doubles. Differentiation of the pineal gland ends by 7 years. Dysfunction of the pineal gland is observed with its aplasia, proliferation of neuroglia with the formation of cysts. Calcification is the outcome of destructive changes after inflammatory process. Epiphysis, hemorrhages, necrosis. Possible development of tumors of the pineal gland, cytomas and pineoblastomas. The pineal gland controls not only all rhythms, hormonal cellular, but also secretes as a hormone melatonin, a hormone of aplasia. Melatonin relieves all negative pain reaction, and endorphins are released in the brain tissues. Thyroid. The rudiment of the thyroid gland in the human embryo is clearly detected by the end of the first month of intrauterine development, with the embryo being only 3.54 mm long. It's located at the bottom of the mouth, and it's thickening of the ectodermal cells of the pharynx along the midline of the body. From this thickening and outgrowth is directed to the underlying mesenchyme, forming an epithelial diverticulum. Elongating the diverticulum acquires a bipartite structure in the distal part. This talk connecting the thyroid enlarge with the tongue, thyroid duct, becomes thinner and gradually fragmented, and its distal and differentiates into the pyramidal process of the thyroid gland. In addition, two lateral primordia, which are formed from the caudal part of the embryonic pharynx, take part in the formation of the thyroid gland. The first follicles in the gland tissue appears at 6-7 weeks of intrauterine development. Vacuolus appears in the cytoplasm of cells at this time. From 9-11 weeks, among the mass of follicles, the appearance of colloid drops is noted. From week 14, all follicles are filled with colloid. The thyroid glands acquired by the ability to absorb iodine by the time of colloid appears in it. Thus, by the 4th month of intrauterine life, the thyroid gland becomes fully formed, structurally and functionally active. With each, the size of the nodules and the content of the colloid increase, and the gland columnar epithelium disappears, and flat epithelium appears. The number of follicles increases. The gland acquired final histological structure only after 15 years. The main thyroid hormones are iodine-containing hormones, thyroxine and T4 and T3. In addition, the thyroid gland is the source of another hormone, thyroxine, which is produced by the C cells of the thyroid gland. Being of polypeptide consisting of 32 amino acids, it is of great importance in the regulation of phosphorus-calcium metabolism, acting as a thyroid hormone's antagonist. The function of the thyroid gland to produce calcitonin matures yearly, and the fetus has high levels of calcitonin in the blood. In the postnatal period, concentration of calcitonin in blood decreases and makes up 30-85 grams per cent. A significant part of tyranny is formed not in the thyroid gland, but at the periphery, by monodeionation of thyroxine. The main stimulator of formation of T3 and T4 is the regulatory effect of the pituitary gland through a change in the level of thyroid-stimulating hormone. The regulation is carried out through mechanism feedback. Increase in the blood level of the circulation T3 inhibits the release of thyroid-stimulating hormone. High voltage T3 has the reverse effect. Maximum level of thyroxine, theanine, and thyroid-stimulating hormones in the blood serum are reigning in the first hours and days of life. This indicates as an essential role of these hormones in the process of postnatal adaptation. Indirect methods for assessing the function of the thyroid glands include determining the size of the gland and the following. Determination of the enlargement of the thyroid gland. Any enlargement of the thyroid gland is called goiter. Goiter can be diffuse or nodular. The nature of the tumor. Endemic and sporadic. With an enlargement in the thyroid gland or severity of goiter, according to simple physical data, it is customary to distinguish 5 degrees. First degree, an enlargement in the thyroid gland is captured only when using the palpation method, but is imperceptible during examination. Second degree, an enlargement of the gland can be seen on examination, but only when the head is thrown back. Third degree, enlargement is ascertained visually in with the usual head position. Fourth and fifth degrees, a pronounced enlargement leading to the flexion of the neck. Ultrasound examination of the teeth reviews structure, shape and size, volume of the thyroid gland. The modern technique of ultrasonography makes it possible to assess the density of the gland tissue, the uniformity of the structure, the diffusence of focal lesion, presence of hyperechoic and hypoechoic zones formed by nose and teeth. Study of bone age carried out by X-ray. It can detect a slowdown in the appearance of classification points with an insufficiency of the thyroid gland. Hyperfunction. Study of cholesterol in the blood. Hypercholesterolemia indicates a hyperfunction of the thyroid gland. Research of the basic metabolism. It is reduced by hyperfunction, increased with hyperfunction. Other signs of hyperfunction: decrease in creatinuria and change in the ratio of creatinine in urine. An increase in beta-lipoproteins, a decrease in the level of alkaline phosphates, carotenemia, and insulin sensitivity. In the same group of indirect methods, it is possible to include the study of anthropometric data, in particular the growth rate of long bones or segments of the bone skeleton, as well as tests of neurophysiological development or intellectual function, which are medically closely determined in the aerodynamics by activity of the thyroid gland and iodine security. Clinical aspects of thyroid lesion. Thyroid dysfunction can manifest in a wide range of pathological and borderline syndromes and diseases. Congenital hyperthyroidism is a disease that threatens a child with severe consequences for both physical and intellectual development. At the same time, the disease can be detected already in the first day of life by screening tests for blood TSH activity, and the likelihood of disabling consequences can be minimized by means of replacement therapy from 2-3 weeks of age. The incidence is about 1 in 3,000 newborns. It is mainly agencies and aplasia of the thyroid gland. However, other congenital diseases may also occur. So, in 1 in 10,000 newborns, the inability to synthesize thyroxine protein occurs. Secondary and tertiary congenital hyperthyroidism occurs with a frequency of 1 in 100,000. In the period of intrauterine development, the fetus actively uses small amounts of the thyroxine that penetrate the placenta, concentrating these hormones also exclusively in the substance of the brain and transforming into triiodthyronine with the help of specific cerebral DNAs. After childbirth, the supply of is interrupted and can be fully compensated by the amount of thyroxine that comes with native breast milk. At the age of 2, after 2 weeks, the increasing manifestation of clinical implication of hyperthyroidism begins. Often these babies are born from a pregnancy that lasts 42 weeks or more, with a body weight close to 4 kg or more. They can have a relatively low body temperature, an increased frontal size, a pulse with tendency to bradycardia, and often heart block. They have prolonged jowls. The following readily forms are a large tongue, a distended abdomen, various hernias, dry skin, hoarseness when screaming, muscle hypertension, constipation lacking reflex dynamics, and motor development. Syndrome of hyperthyroidism. The child has growth retardation, the rigidity of facial features, thick lips, a large tongue, sunken nose, periorbital edema, or parasitinus. The skin is pale, dry, and flaky. Hair is pale and dull. Sweating is reduced. The extremities are cold, hypersensitivity to cold. Subcutaneous fat is loose and edematous. Myxedema, mucosedema, or the subcutaneous fast. Cardiovascular system, sinus bradycardia, and heart block. EKG changes, low voltage waves, or the QRS complex. Neuromuscular system, muscle weakness and hypertension, myalgia, pseudohypertrophy of muscle, rosiness and lethargy in reactions, paresthesia, cerebral ataxia, retardation in psychomotor and speech development. The skeletal system lacks embryological age in terms of ossification, physical dysgenesis, and increased deterioration of the upper to lower body segments, pathology. Laboratory an increase in the level of creatine phosphokinase, hypercholesterolemia, hyperprolactinemia, anemia with macrocytes. Thyrotoxicosis is a syndrome caused by increased production of thyroid hormones. Thyrotoxicosis in newborns, usually transient, develops rarely, is caused by a transplacental transfer of maternal thyroid stimulating antibodies and ends in 3-12 months. Babies with congenital thyrotoxicosis are usually born prematurely, and full-term babies have intrauterine growth retardation and low body weight. Usually they observe tachycardia, sometimes arrhythmia, increased excitability and motor activity. Sweating, increased appetite with poor weight gain. Exophthalmos is often noted. Goiton is palpated. In some cases, there are microcephaly and expansion of the ventricles of the brain. Hepatosplenomegaly and jealousy are possible. Thyroiditis is an inflammatory disease of the thyroid glands, usually characterized by its enlargement. In some cases, pain and dysfunction. Acute thyroiditis is a rare condition, usually caused by gram-positive bacteria. With this disease, formation of an abscess is possible. Subacute granulomatosis thyroiditis in children is rare. The case of its development is considered a viral infection. In the initial period, patients may develop thyrotoxicosis. Autoimmune thyroiditis is an organ-specific disease characterized by production of antithyroid antibodies to metrosomal argentum, thyroglobulin, and others, and cytotoxic reactions. In children, the hypertrophic form prevails with infiltration of the thyroid gland with lymphocytes and plasma cells, the presence of Ashkenazi heart cells, and moderate fibrosis. Autoimmune thyroiditis can lead to hypothyroidism. Parathyroid glands. The parathyroid glands secrete parathyroid hormones (PTH) into the blood, the main function of which is to maintain constant concentration of calcium and phosphorus ions in the blood. PTH increases concentration of calcium ions in the serum by activating osteoclasts and enhancing bone resorption, as well as increasing the absorption of calcium ions in the distal renal tubules. For newborns, physiological hypocalcemia is characteristic, caused by a sudden cessation of the flow of calcium ions from the mother and inability of the parathyroid glands to mobilize calcium ions from bone tissue. The hypercalcemia effects of PTH is also inhibited by calcitonin and cortisol, which are released after childbirth. The system that ensures constancy of concentration of calcium ions in the blood serum is finally formed by the end of the neonatal period. The maximum functional activity of the parathyroid glands occurs in the first 2 years of life, when osteogenesis is especially intense. The parathyroid glands are inaccessible to physical examination methods. However, upon questioning and general examination, clinical signs of dysfunction of the parathyroid glands can be detected. They also use ultrasound radioisotope scanning, CT, computer tomography, thermography, and read and objective methods for assessing the function of the parathyroid glands is the determined concentration of PTH in the blood. In addition, concentration of ionized and total calcium and phosphorus in the blood serum is examined, as well as their excretion in the urine. The concentration of calcium and phosphorus ions in the urine with a change of the content of PTH is inversely proportional to their content in the blood. Hypoparathyroidism is a syndrome caused by PTH deficiency. All forms of hypoparathyroidism are characterized by hypocalcemia and hyperphosphatemia with low PTH concentration. The clinical manifestations of hypocalcemia are mainly due to impaired neuromuscular conduction. In newborns, this condition manifesting increased excitability, a person crying, muscle twitching, seizure, arrhythmias. In older children, tetany and presbyceas may develop. Severe hypocalcemia can lead to a decrease in cardiac output and a drop in blood pressure. With hypoparathyroidism, attack of tonic seizures occurs, which size mainly symmetrical muscle groups, flexors, and develop in response to tactile irritation during examination, swelling, overheating after injury, etc. Convulsion often appears in the upper limbs, but can also be in the lower ones, as well as the facial muscles. In addition, with hypocalcemia, prosthesia, hyperreflexia, laryngospasm, spasm, and spastic contraction of the intestine occurs. Hyperparathyroidism is a syndrome that occurs when is excess of PTH. This clinical picture is primarily associated with hypercalcemia, characterized by weakness, malaise, polydipsia, polyuria, isostenoria, vomiting, constipation, abdominal pain in young children, delayed physical development. In addition, patient may have muscle lesions, muscle gout, gout, chondrocalcinosis, erosive arthritis. X-ray reveals cystic oocytes with densitometry, a decrease in bone density which increases the risk of bone ruptures. Cysts and tumors are often found in the bones. Increase in excretion of calcium ions leads to urolithiasis and nephrocalcinosis may develop. Possible arrhythmias, shortening of QT interval of EEG, arterial hypertension. Adrenal glands. In the adrenal glands, two layers of subcutaneous are distinguished, cortical and medullary, with the form accounting for approximately two-thirds of the total mass of the adrenal gland. Both layers are endocrine glands. Their function are very diverse. In the adrenal cortex, corticosteroid hormones are formed, among which glucocorticoids, cortisol, mineralocortisol, aldosterone, and androgens are of the great importance. In the medulla, catecholamines are formed, of which 80–90% are adrenaline, 10–20% are norepinephrine, and 12% are dopamine. The adrenal glands are laid in humans on the 22nd–25th day of the embryonic period. The cortical substance develops from the mesothelium, the cerebral from the ectoderm, and some watch the cortical. Weight and size of adrenal glands depend on age. Histologically, three zones are distinguished in the adrenal cortex: zona glomerulosum, producing mineralocorticoids, aldosterone; zona circulatum, producing glucocorticoids; and zona reticularis, producing androgens. Hypocorticism is a decrease in the function of the adrenal cortex and adrenal insufficiency. Chronic adrenal insufficiency manifests in children in generally weakness, rapid fatigue, delayed development, anorexia, loss of body weight, hypoglycemia, occasionally nausea, vomiting, liquid feces, pain in the abdomen, arterial hypertension. In primary chronic adrenal insufficiency, besides the mentioned symptoms, the following are known: hyperpigmentation of skin and mucous membranes, a consequence of chain separation of ACTH, and increased demand in this salt, hyponatremia and hyperkalemia. Primary genital chronic adrenal insufficiency most often develops in children with defects in the enzymes of steroidogenesis, less often with hypoplasia of the adrenal cortex. Congenital dysfunction of the adrenal cortex is a group of hereditary disease in which the synthesis of cortisol in the adrenal cortex and the accumulation of metabolic proceeding the defective stage of steroidogenesis are impaired. There are 5 variants of congenital adrenal cortex dysfunction, which have different manifestations in children. Acute adrenal insufficiency is characterized by general serious condition of the patient: severe weakness, acidemia, anorexia, vomiting, abdominal pain, loose feces, increasing shortness of breath, cyanosis, falling blood pressure, weak pulse, in some cases convulsion, loss of convulsus vascular collapse. Hypercortisolism, hypercirculation of corticoids can be primarily due to small nodular or nodular hyperplasia of the cortex, adenoma or malignant neoplasm of the adrenal glands. Secondary hypercortisolism occurs with excessive secretion of ACTH by the hypothesis of ectopic secretion of ACTH by non-pituitary tumors. Pancreas. The pancreas is located between the duodenum and the spleen. in front of and across the vessels that run along the spine. In front, it's covered with a peritoneum. The glands is richly vascularized. The endocrine tissue of the pancreas is represented by pancreas islets. In the pancreatic islets, A cells that produce glucagon and P cells that produce insulin are distinguished. Insulin synthesis and secretion is mainly stimulated by glucose. In the blood, insulin is found in free and bound forms. Glucagon has a generated genesis effect, which is associated with its hypoglycemic effect. The endocrine function of the pancreas is studied mainly in connection with its effect of carbohydrate metabolism. Therefore, the main thing is to determine the level of sugar in blood. Insulin secretion depends on concentration of glucose in the blood. The secretion is related by an increase in concentration of both hormones, acetylcholine and gastrin-releasing hormones, and suppressed by somatostatin, adrenaline, and epinephrine. Glucose inhibits glucagon secretion. Hyperinsulinemia is relatively rare. The most common cause of its development in children are pancreatic cells hyperplasia or insulinemia. Transient hyperinsulinemia occurs in newborns born to mother with diabetes mellitus or pregnancy diabetes, as well as on the background of HDM. Hyperinsulinemia is administered by the syndrome of hypoglycemia. In newborns and infants, clinical symptoms of hypoglycemia include lethargy, drowsiness, hypothermia, slight sucking, cyanosis, apnea, and surgeries. Diabetes. Cause of diabetes mellitus, so diabetes, it's hyperinsulinism. Cause of diabetes mellitus is a deficiency of insulin or resistance of target cells to its impact. Diabetes mellitus is classified in two main types. Type 1, insulin-dependent, occurs due to insufficient insulin secretion due to destruction of B cells. In most causes, type 1 diabetes is caused by an autoimmune process. The disease can be induced by viral infection and some toxic substances. Classic clinical manifestations of diabetes mellitus are polydipsia, polyuria, young children, enuresis, weight loss, dry skin, and mucous membranes, polyphagia, weakness, fatigue, and frequent infection often occurs. In infants, greed is noted when sucking and decrease or stop in weight gain. A symptom start with diaper, rash, stomatitis. The main biochemical signs: hypoglycemia, glucosuria, ketonuria, lack or low concentration of insulin and C-peptide in the blood. Type 2. Diabetes mellitus, non-insulin dependent, is associated with insulin resistance, relatively insulin deficiency. The disease rarely develops in children, mostly at puberty. Monogenic forms of non-insulin dependent diabetes mellitus are caused by defects in single genes, while insulin secreting is usually initially impaired, but most are polygenic in nature, in which insulin resistance is the primary disorder. Non-genetic risk factors for the development of non-insulin dependent diabetes mellitus include obesity, in which insulin resistance occurs, and in severe cases, impaired insulin secretion, as well as overeating, a sedentary lifestyle stress. In young children, intrauterine growth, retardation, starvation. Secondary diabetes mellitus can be caused by disease of the pancreas, cystic fibrosis, hemochromatosis, pancreatectomy, or an excess of glucocorticoids. Sexual glands, sexualization, and puberty. The process of formation of the sexual phenotype in child takes place during the entire period of development. But the most significant in this regard are two periods of life, being rather short term. This is the period of sex formation in intrauterine development, which generally takes about 4 months, and the period of puberty. In utero, male and female sex glands develop from one common differentiated rudiment and undergo two phases in development, natural and specific. The natural phase of development lasts up to 6 weeks of intrauterine period. The developing gonad is morphologically the same for both sexes and consists of the cortical and medullary layer. So in a specific phase, the ovary is formed from the cortical layer, and the testicle is formed from the medulla. Sexual Y chromosome plays a major role in the transformation of the gonad into a testicle. The embryonic testicle is capable of secreting non-hormonal substances that causes atrophy of the mullerian ducts. Without antimullerian factor, regardless of the genetic sex of the embryo, the mullerian ducts persist and forms the uterus, fallopian tubes, and parts of the vagina. Mesonephral ducts are formed into the epididymis, seminal ducts, and seminal vesicles under the influence of the androgens of the embryonic testes. Androgen secreted by Leydig cells are also necessary for the descent of the testicles from the abdominal cavity to the scrotum. This process starts from third month of the embryonic period and ends by the time of birth. This scrotum and penile urethra are formed. The research methodology for sex and puberty. The most common complaints of a child of his parents are late or premature appearance of signs of puberty, as well as structural features of the external genital organs. When collecting analysis, it is necessary to take into account the declaration of puberty in the child's parents, other children in the family, or close relatives. It may be noted a similar advance or retarded in duration of sexual development. There may be childless relatives or not entering into marriage by reason of pathology in the sexual sphere. So, general information you can see here, general examination, and stages of acceleration. Thank you for your attention. Goodbye.